All right, I'm going to start off. So my name is Prabir Roy-Chaudhury. I'm a nephrologist at the University of Arizona, and I am delighted to have been invited to give this webinar. The topic that I'm going to talk about today is dialysis vascular access, and I have termed this as a tale of biology, technology, and process of care. These are my disclosures, as you can see on the slide. So I'm going to divide this talk into three main parts. I'm initially going to tell you a little bit about the pathology and pathogenesis of dialysis vascular access dysfunction. And in particular, I'm going to focus on the interactions between hemodynamics and uremic vascular biology that I think are critically important. I'm then going to use this information to tell you a little bit about some novel therapies that target both hemodynamics and uremic vascular biology in the setting of dialysis vascular access. At this point in the talk, I will actually shift a little bit and tell you a little bit about process of care pathways to improve dialysis vascular access care, in particular arteriovenous fistula maturation. And then finally, I will end with some messages for the future. I want to start off, though, with some messages for the present. And in my mind, that message really very clearly is that our current modalities and therapies for dialysis vascular access are really not very effective. The primary patency for fistulae and grafts is about 50% at 1 year, between 50 to 60%. And this, of course, results in widespread use of tunnel dialysis catheters with all of its attendant morbidity and mortality. So clearly, there is a huge unmet clinical need, I think, that needs to be addressed in this area. Now, this slide describes to you the classical radiological presentation of dialysis vascular access dysfunction. And I'm really going to focus on the panel to the left. And you can see over here an angiogram of an arteriovenous fistula soon after creation, and you can see this very tight perianastomotic stenosis, which is often responsible for fistula non-maturation. Now, if you take tissue from this region over here and look at it under a microscope, and we have done this repeatedly both within our group and in the context of a large NIH study, you then get, if you do this, what I have termed as the histological presentation of arteriovenous fistula maturation failure, which, if you look at the panel on the left, is an aggressive venous neointimal hyperplasia, which is made up of smooth muscle cells and myofibroblasts, and in fact, on some occasions, fibroblasts as well, which have migrated in from the media and perhaps also from the adventitia in response to hemodynamic stress and surgical injury. Now, it's very, very important to realize that even though neointimal hyperplasia is important, the final amount of luminal stenosis, as shown over here, is always as a result of a combination of neointimal hyperplasia and either a lack of positive or outward remodeling or a very significant amount of inward or negative remodeling. So again, I think this is an important concept that seems to be becoming more and more important, since we're now having studies that demonstrate that even if you have a lot of neointimal hyperplasia, you don't necessarily have to have a failed fistula. So I think the outward or positive remodeling is extremely important. So with that sort of brief background or overview of dialysis access dysfunction, I'm going to try and take you through what happens when you create a vascular access. So when you create a vascular access, be it a fistula or a graft, you initially have increased flow. And this increased flow then results in an endothelial production of nitric oxide. Now, nitric oxide is critically important because not only does it inhibit neointimal hyperplasia, but it also causes the expansive or outward remodeling in our minds that I spoke about earlier. And the end result is a successful arteriovenous fistula or graft. Now, the other way to speak about or describe this construct is that following creation of a vascular access, there is an initial increase in flow, which is followed by a vascular response to this increased flow. Yet another way of describing this paradigm is that following creation of a vascular access, be it a fistula or a graft, there is in fact an interaction between upstream hemodynamics, which is flow, and downstream uremic vascular biology, which is the response to flow. And at the end of the day, it's really this interaction between the hemodynamics and the vascular biology response that results in either vascular access, success, or failure. What I'm going to do now over the next 15 or 20 slides is really to dive into the biology, and I'm really going to focus both on flow and on uremic vascular biology. So let's talk about flow. So this is a slide that comes from work that is really now over 25 years old, and it basically makes the point that the pattern of blood flow over an endothelial cell is critically important in determining that endothelial cell's characteristics and function. So if you look at the left panel, you see that you have a situation where the blood flow is static. And in this case, you can see that the cells acquire a polygonal appearance. If you look at the middle panel, you see that the blood flow is actually directed over the cells in a particular direction. In this case, you have a stellate appearance of the cells which orient themselves in a particular direction in the setting of laminar flow. And then finally, if you have turbulent cells, you get a situation where the cells basically look sick and die. Now, even though flow is critically important, I would argue that the most important hemodynamic factor which influences, particularly in my mind, vascular remodeling or this outward or positive or negative remodeling is shear stress. Now, shear stress is defined as the viscous drag of blood on the cells lining the vessel wall. Shear is directly proportional to the velocity of flow, and it's inversely proportional to the radius of the blood vessel. And even though shear is critically important, what is perhaps even more important than the absolute value of shear is the actual type of shear. This is a somewhat complex slide. It describes to you the carotid bifurcation. I've termed it Hemodynamics 101. Now, if you look at the right part of the slide over here, you see that the flow vectors are all nicely lined up, one on top of the other. So this is an example of laminar flow or laminar shear or high shear. And in general, in vascular biology, this sort of flow and shear profile generally results in good things. It results in endothelial quiescence, in minimal oxidative stress, in a non-inflammatory gene profile, and in the context of an arteriovenous fistula, I would argue that this sort of flow and shear profile results in minimal neointimal hyperplasia, a lot of outward remodeling, and at the end of the day, a successful dialysis access. On the other hand, if you look at the panel on the left, you see that the flow vectors are going round and round over here. This is an example of non-laminar flow or oscillatory shear, where the blood is actually going back and forth over the vessel wall. And in general, this results in endothelial activation, in an increase in oxidative stress, and in an inflammatory gene profile. And we would argue that in the setting of an AV fistula, this sort of flow and shear profile will result in bad things, in more neointimal hyperplasia and a more aggressive inward remodeling. And really, as proof of this, which I've always found very, very interesting, if you think about the carotid bifurcation, the maximal amount of atherosclerosis actually occurs in this region over here, where you have the non-laminar shear profiles. So again, just to emphasize what is really a simple point, but I think is a fundamental point, and that is that laminar flow and laminar shear in general results in happy endothelial cells, non-laminar flow and oscillatory shear results in unhappy endothelial cells. And I would argue that regardless of whether it's vascular access or coronary artery disease or peripheral vascular disease, it's always much better to have happy endothelial cells as compared to unhappy endothelial cells. So with that background, one of the major interests of our research group over the last probably now 8 to 9 years has been an attempt to try and establish linkages between hemodynamic shear and histological stenosis. And I apologize, this video is not playing, but in order to do this, what we've done is we've developed a pig model of arteriovenous fistula stenosis, where we basically connect the femoral artery in a pig to the femoral vein in this configuration shown over here. And in our initial studies, we created this fistula, and then we actually took the pigs at different time points up to a CT scan. This was a very nice 64 slice CT scan. We had to get the pigs into the scan and then out of the scan before the actual patients came in. But what the CT scan of the arteriovenous fistula allowed us to do was that it allowed us to get obviously a CT angiogram, but this could then very quickly be converted, as you can see over here, into a three-dimensional mesh framework. And just to orient you, a mesh framework of the fistula. So just to orient you, this is the proximal artery, the anastomosis, and the venous segment. We then did an ultrasound of the fistula to get a value for flow. We plugged the flow into the three-dimensional mesh framework, and that allowed us to develop a three-dimensional wall shear stress profile, with the oranges and reds indicating high shear, usually laminar shear or laminar flow, and the blues or greens indicating low shear, often oscillatory shear. And of course, what we found was that there were very different shear profiles between, let's say, the inner wall of the fistula as compared to the outer wall. When we looked at the actual flow profiles, and you can do this using computational fluid dynamics, we found that in general on the inner wall, you had the flow vectors going round and round as in my earlier example, but you had the flow vectors nicely laid upon each other on the outer wall of the AV fistula. And then in other pigs, when we actually looked at the expression of inflammatory markers, such as monocyte chemoattractant protein 1, for example, we were able to demonstrate, and this was exciting for us, that the MCP1 expression on the inner wall was hugely greater as compared to the MCP1 expression on the outer wall, suggesting to us at least that the hemodynamic flow profiles were actually influencing the MCP1 expression, with regions of non-laminar or oscillatory shear resulting in high MCP1 expression, while the regions of laminar flow resulted in low MCP1 expression. Now, since that time, we're currently using this pig model to really dive a lot deeper into the molecular biology of arteriovenous fistula stenosis. In other work, we've been able to demonstrate very significant differences in overall gene expression for different proliferative pathways in different areas in the arteriovenous fistula. And we believe that this is driven by differential hemodynamics. And we are beginning to use both network and bioinformatic analyses to try and identify new druggable targets for arteriovenous fistula maturation failure. In addition, what we've been able to show in previous work, now probably about 8 years old, is that the surgical configuration of the fistula can actually influence, obviously, the flow and shear stress profiles, as shown on this slide when you compare a curve to a straight fistula. What was particularly, I think, interesting to us was that these differences in flow and shear then seem to translate into actual differences in hard clinical parameters that all of you would consider to be important, such as blood flow and diameter, with the curved fistulae actually doing better than the straight fistulae in these initial studies. And the reason that this is important, of course, is that if in fact we are able to optimize the anatomical or surgical configuration of the vascular axis in the future using surgical devices, let's say, such that we're able to achieve an ideal flow and shear stress profile. And I think we still are not completely clear as to what this ideal flow and shear profile is. But if we were able to do this, then perhaps we would be able to reduce the local inflammatory response and also reduce vascular access failure. So at this point, I'm going to shift gears a little bit. So everything I've told you about till now is all about how hemodynamic forces can influence the endothelial response. But what about the intrinsic function, or really dysfunction, of the baseline endothelial cell, and how does this influence its response to shear stress alterations? And the reason that this is important is that all of us know that both chronic kidney disease and end-stage renal disease are in fact states of massive endothelial dysfunction as a result of uremia and oxidative stress and inflammation. And perhaps some of the best work in this area comes from a paper by Dr. Choi, in which he was able to demonstrate that if you create an arteriovenous fistula in a uremic mouse, that you get much more aggressive neointimal hyperplasia as compared to similar fistulae created between the carotid artery and the jugular vein of normal or non-uremic animals. And within our lab, we've really, I think to a very great extent, developed a very similar model. When we create this model, we do find neointimal hyperplasia at 14 days, as seen in the right panel. And we have really tried to use this uremic mouse model to try and dissect out the differential, or really, in my mind, synergistic effects on gene expression of uremia and hemodynamics. So in this slide, you really see the gene expression of monocyte chemoattractant protein 1, the same molecule we spoke about earlier, in different settings. And I just want you to focus on the red bars. So if you look at the first set of bars, you see that if you take a jugular vein and keep it without a fistula in a mouse for 2 weeks, that the gene expression of MCP1 in that uremic vein without a fistula is about 3.5 times greater as compared to the level of MCP1 in a vein from a non-uremic animal, no fistula at all. So we believe that this increase is as a result of uremia. Now, if you take another mouse and you create an arteriovenous fistula and you look at the gene expression of MCP1 after 2 weeks in the venous segment of the fistula, you get a 12-fold increase in MCP1 gene expression. And we believe, of course, that this increase is as a result of hemodynamics, because these mice are now not uremic. But, and this is the key result, if you take a uremic mouse and create an arteriovenous fistula, you get up to a 30-fold increase in the gene expression of MCP1. And we believe, of course, that this is as a result of both hemodynamics and uremia together. So how does one put all of this together? Well, we very strongly believe that if, in fact, as a community, we want to be serious about minimizing vascular access dysfunction in the next decade, that we need to focus not only on optimizing upstream hemodynamics, the flow part of it, but we also need, obviously, to optimize downstream uremic vascular biology or the response to flow. And I would argue that be it an attempt to alter hemodynamics or uremic vascular biology, we probably need to think out of the box more than we have been thinking in the past, even I would say very strongly in my career, because we're really not that much ahead as compared to 5 or 10 years ago to some extent. So with that, what I'm going to do now in the second part of my presentation is really to talk about some novel therapies. And the goal here is really just to give you a feel of how some of the scientific and biological principles that I described to you are actually being used to develop therapies that target hemodynamics and vascular biology. I want to start off by talking a little bit about basically a device that our group is developing through a small company called Innovasc, and this is a biodegradable maturation enhancing stent for early maturation failure. And the background to this is that about 5 years ago, we really tried to identify the most important pathogenetic pathways responsible for fistula maturation failure. And we came up with 3 important pathways. Number 1, small vessels that result in poor blood flow. Number 2, bad hemodynamic profiles, which result in a lack of outward remodeling and a more aggressive neointimal hyperplasia. So very similar to what I spoke about earlier. And number 3, bad vascular biology as a result of uremia and inflammation and oxidative stress that results in a lack of outward modeling or remodeling and a more aggressive neointimal hyperplasia. So then the next question was, is there a device or a drug that can target all 3 of these pathways? And the device that we came up with was really a biodegradable stent made out of magnesium that was placed in the fistula right at the time of fistula creation, as shown here in a pig. And the reason we felt that this might work was that we felt that the actual scaffold of the stent would increase flow and diameter. Ultimately, we definitely want the stent to be malleable so that it could be curved into just the right anatomy and so generate just the right hemodynamic profile. And we also feel that this stent could actually be coated with a drug or a cell or a gene or a chemical that would improve local vascular function. The most important part of this biodegradable stent, or the most important aspect we felt, was that the stent would give us the opportunity to optimize the local biological and hemodynamic milieu in the critical 4 weeks after fistula creation, where the rubber really hits the road. So this is the period where you have surgical handling, you have hemodynamic shear, you have fistulae being placed, and if you can tweak the biological and hemodynamic system enough in our minds in this period of time, you would likely, we feel, get a good long-term result if you tweak it in the right direction. At the same time, because the stent is biodegradable, it stays in place only for 4 to 6 weeks and so avoids the long-term negatives of stenosis and thrombosis that you always get when you place a foreign body in the vascular tree. Very quickly, we've developed a large number of stent iterations from the very basic on the left to much more sophisticated types of stents. The panel on the left describes a stent being placed into a fistula at the time of fistula creation in a pig, and the panel on the right shows you the stent being dilated out. And of course, a video is much more descriptive than an actual picture. I apologize for the noise. I forgot to put it on mute, but over here you see the stent actually being placed into the fistula at the time of creation. And then in the next slide, whoops, and then in the next video really, you see the stent actually being dilated up, and over here you can actually see the stent within the venous segment of the arteriovenous fistula. These two slides are described to you. On the left, an arteriovenous fistula with the stent in place, and on the right, an arteriovenous fistula in a pig without a stent. This is what it looks like in terms of efficacy, and we're beginning to get some data on this. Again, on the left over here, you see an arteriovenous fistula in a CT angiogram in a pig, and you see a very nice open fistula over here on the stented side at 17 days after surgery. And on the control side, you see a relatively tight stenosis, similar actually to what you see in human arteriovenous fistulae. And then again, most importantly, we've been able to demonstrate that most of the stent actually disappears by 30 to 60 days. And we are excited about the potential of this new therapy. So that was novel therapy number one. Novel therapy number two, and I'm going to take a sip of my coffee here. So novel therapy number two is something that there is a lot of excitement about, and that is the creation of an arteriovenous fistula using endovascular techniques. So no surgery at all. And the biological rationale for this is shown on the upper left of the slide. And it basically states that when you create a fistula, there's a lot of handling, there's a fair amount of torsion, and it's this torsion and handling that results in the perianastomotic stenosis. So if you were able to create a fistula without the surgical handling, then perhaps that would actually work very well. And there is a company actually called TBA, and I am involved in the company, so on their clinical advisory board. So this is a conflict that I want to point out. But basically, they've developed a system of catheters and wires which allows two catheters to be placed close to each other, one in the artery, one in the vein, through the use of magnets that are within the catheters. And again, a video, I think, describes this much more effectively. And over here, you see basically initially guide wires placed into the ulnar artery and the ulnar vein. The catheter from the company called the Everlink catheter is then placed over these wires as shown over here. The catheters have the magnets which bring the arterial and venous catheters, the artery and the vein together. There's then a little device in the middle of the magnets that gives you a radio frequency blast. That creates a hole between the artery and the vein. The catheters are removed, blood flows through the endovascular fistula, and then a coil can actually be placed, as you saw in the deep veins, so that most of the blood goes up through the superficial veins, and needles can then be placed into it. And again, just into the fistula, or the endovascular fistula. And again, this is what it actually looks like. Over here, you have the point where the fistula was created, and you have the two veins, superficial veins, that have been created or enlarged. And again, over here, you can see a very nice fistula with no surgical scar or trauma at the creation site. So again, whether this will result in a fistula with better patency, I think is still unknown, but the technique at least is actually, I think, very, very interesting. And then finally, the third novel therapy that I want to speak about, and this is in the middle of a phase 3 clinical trial, is on tissue engineered grafts. And again, The biological background over here is that you get aortic mesenchymal cells from a human donor and you store them. You then grow these cells up. The cells are then added into a biodegradable scaffold or are seeded into a biodegradable scaffold. And when this happens, the cells do what cells always do. They basically produce matrix components. And at this point over here, you actually undergo a decellularization procedure to get rid of the cells so that you don't have any chance of having an alloimmune response. And when you do this, you're actually left with something that very much looks like a vessel as shown over here. Does this actually work in patients with kidney failure? The answer is yes. There was a paper that was published by Jeff Lawson in the Lancet, which shows that at a year after creation of this bioengineered vascular access being placed in a dialysis patient, you actually get a very significant amount of recellularization. What was even more important in my mind was that as early as 16 weeks after placement, they actually had some endothelial cells lining the surface of the graft. So very impressed by the histology. What about the patency? And the answer is that it probably works just as well as a PTFE graft. The Lancet paper did suggest that there was a decrease in the number of interventions needed to maintain that similar patency in the bioengineered vascular access group. The hope is that there will be less infection and less aneurysm, but again, the results of the phase 3 pivotal study should hopefully be available soon, and that's going to determine whether or not these bioengineered vessels for vascular access actually result in a better patency. So at this point, I am going to move away from biology. I'm going to move away from technology, and I'm going to talk a little bit about what I think is the most important part of vascular access, which is the process of care. This is a critically important slide, and what it demonstrates is that if you have 100 patients starting dialysis in this country, about 80 of them actually start dialysis with a tunneled dialysis catheter. And this is a number that is high throughout the world. I think the US does much worse than Europe and Asia, but even in Europe and in Asia, the figures are probably 50 to 60% starting with dialysis with a catheter. The reason that this is important is that there's a lot of data which shows that there is a very significant increase in mortality in patients starting dialysis with a tunnel dialysis catheter as compared to patients starting dialysis with a fistula or starting on PD. And I would argue very strongly that this up to a 5-fold increase in mortality in the first 90 days in particular is a disgraceful statistic. And it's disgraceful because this is not as a result, in my mind, of a failure of technology or biology, but it is a dismal failure of communication and logistics and process of care. So what's the way that one can get every patient to start dialysis with a fistula? And it's not rocket science. It's shown on the slide. We need early referral to a nephrologist. You need vein preservation techniques. You need to refer the patient early for mapping and surgery. You need to send your patients to a good surgeon. We'll talk in a moment what a good surgeon actually is. We need the patient to be in a setting where there is not a long wait for the fistula to be placed. And then it's very important that fistula is followed up so that at 4 to 6 weeks or even earlier, if it's not working well, the patient can be referred for angioplasty or surgery. Most importantly, when the fistula is ready to use, or I would actually take a step back, most importantly, when the patient is ready to start dialysis, because all of this needs to occur in the CKD phase, then it's very important at this point for an expert cannulator to actually do the initial needling. The problem, of course, is that there are process of care barriers at each and every one of these steps. And I think all of you are familiar with that. I'm going to talk about just a couple. So the first is nephrology follow-up. So this is USRDS data. And basically what it shows is that if you have a patient who has never seen a nephrologist, that 80% of these patients will start dialysis with a tunnel dialysis catheter with no other fistula or graft or other access in place. However, if a patient has seen a nephrologist for more than 12 months, this number goes down to 40%. It basically halves. So you can look at this data and you can say that, wow, nephrologists are doing a really good job, 50% reduction in incident tunnel dialysis catheter use. On the other hand, you could look at it as the way that I look at it and really ask the question that if you've seen a nephrologist for more than 12 months, why are 40% of patients starting with a catheter and not with an arteriovenous fistula? And in fact, this has been looked at by a group in Australia, and they were able to demonstrate that an important reason was the late referral by nephrologists to surgeons of these patients for fistula creation. So this time I'm going to put on my nephrology hat and I'm going to say, well, I can tell you why that happens. There's a fair amount of unpredictability as to when patients will start dialysis. And there's also, in many cases, the non-acceptance of the need for hemodialysis for many different reasons. Now, I'm saying this not to make excuses for nephrologists, but really to make the case for more resources, particularly, I would say, access coordinators, so that we can develop coordinated and integrated access care programs during the chronic kidney disease stage. Because if, in fact, there is a battle for dialysis vascular access, it's going to be won or lost in the CKD period. The second process of care topic, so to say, that I want to speak about is about a surgeon. So no question at all, if you want to have a successful vascular access program, you need a good surgeon. But when I say that you need a good surgeon, I'm not just talking about somebody who can connect an artery to a vein. I'm talking about somebody who's interested and dedicated and committed to vascular access. I'm talking about somebody who really has the wisdom to be able to make a judgment call about placing the right access in the right patient at the right time. And we still need these judgment calls because we don't have adequate predictive data to say that this patient's access is going to work and this patient's access is not going to work. So finally, I'm going to end with some messages for the future. And there are actually 5 messages. It's an important area. So the first message is one of precision medicine. So I strongly believe that in the area of vascular access, we need to get away from the one-size-fits-all vascular access paradigm that I think we currently live in. And what we need to do, in my mind, is that we need to stratify our patients based on both clinical and biological parameters, and then individualize their vascular access care in the future by potentially pairing specific novel therapies with specific or particular clinical and biological phenotypes in order to get optimum results. So if you have a 45-year-old non-diabetic patient with, in the future, good vascular biology, not just good veins and arteries, well, they may just need a device that creates good hemodynamics. On the other hand, you have a 65-year-old diabetic with bad vascular biology. This patient may need therapies that target both hemodynamics and reduce overall inflammation. So that is message number 1. Message number 2 very strongly is about process of care. So I've described to you that many of the problems that we have in vascular access are due to process of care issues. I would argue that each of these challenges is actually an opportunity for process of care innovation. And I think there is a huge amount that every country in the world can do with regard to the process of care of vascular access. And I think it has to be different to a very great extent in different parts of the world. Now, if you want to do process of care innovation in vascular access, the one common theme is that it has to be done through a team approach that involves not just the nephrologist and the surgeon or the interventionist, but also a vascular access coordinator and a dialysis unit. And most importantly, you have to have the patient front and center. You have to have the patient involved, otherwise you're not going to be successful. My third message is about more than vascular access. It's really about, I think, dialysis as a whole, but it focuses on the need to synchronize biology and technology with the clinical need or setting. So for dialysis patients, we get these relatively very ill patients with a high comorbidity burden into a high-tech medical environment 3 times a week. But all we do in this time is we get them in, we get them on the machine, we get them off the machine, we get them out of the dialysis unit. And I would argue very strongly that we need to be looking after their hearts and their eyes and their legs and their psychosocial issues and, of course, their vascular access in the dialysis unit. We need to make the dialysis unit a medical home for these patients. I would also argue that we need to convert the dialysis unit into a hub for clinical research and innovation, with potentially the dialysis unit itself being the unit of cluster randomization in pragmatic trials or in large simple trials. And I would argue that there is a huge opportunity to develop technologies that can be used in a positive manner during the dialysis visit itself, both for vascular access care and ESRD care. In fact, I would argue that we need to convert our dialysis units into factories of quality care and research and innovation. And this is, of course, almost laughable at the present time, because clearly our dialysis units do not do this at the present time. And then finally, my last message is, I think, a personal message. And that is that our patients, hemodialysis patients, are complex patients. They have diabetes and hypertension. They've had heart attacks and strokes. They have had amputations. Many of them are legally blind. And in every country in the world, these patients actually face social and economic issues that I think we really cannot understand. And the sad reality, to a very great extent, unfortunately, is that we cannot fix the vast majority of these problems, at least at the present time. But I do believe that the one thing that we can fix is that we can fix their vascular access by combining biology and bioengineering with technology and process of care interventions. And by doing this, I think we can make a huge difference both in their survival and in their quality of life. So with that, I would like to thank all of you for your attention. I particularly want to thank the people I work with, all the members on the left part of the slide in the Arizona Kidney and Vascular Center at the University of Arizona. In the bottom right, you see my collaborators from our company called Innovasc. And in the top right, you see my collaborators, Mark Meyerhoff and Yadong Wang, amongst others from the universities of Michigan and from Cornell. And again, I would like to thank my funding sources. So at this point, Vivek, I'm going to hand over to you.